Good afternoon, everyone. I'd like to thank you each for participating in a unique Virginia Department of Health Project ECHO COVID-19 Tele-ECHO Clinic. This exciting session will be focused on shared experience in healthcare during the COVID-19 crisis, and in lieu of one didactic, we will instead have 4 presenters giving a 10 or so minute presentation on their experience. Quick disclaimer, VDH is rapidly working to develop resources to address COVID-19. Guidance changes and all participants are encouraged to continue their own research. If you have a question, please email ivp@vdh.virginia.gov, and we'll have a timely follow-up response. Next slide, please. This session does count toward continuing education. Credits. VNA has approved 1 hour CNE, and Quillian's Clinic CME program designates this as 1 AMA PRA Category 1 credit. All speakers have no conflict of interest to disclose, and following the session, VDH will post didactic links and information with the evaluation link and instruction for receiving this credit on the VDH Project ECHO website. Closed captioning is also offered for the session. Next slide, please. Some helpful tips. This Tele-ECHO clinic is used for educational purposes, and on participating, you are consenting to being recorded, and recordings will be available on projectechosbox.com, protected by a password. Clinicians can view the recordings later, and materials will be shared with the Project ECHO community. Please mute yourself when you are not speaking, and please do not share information that identifies or can be linked to a patient's identity. Next slide, please. Our facilitator today is Dr. Colin Wozencraft, trained in internal medicine palliative in Richmond, Virginia, before practicing and teaching nationally and internationally, focusing on implementing palliative medicine in developing regions. He now lives again in Richmond, but is retired from clinical practice and continues an interest in medical education, ethics, and economics. Our VDH consultants are Diane Woolard and Carol Jamerson. Diane Woolard is the former director of VDH's Division of Surveillance and Investigation, who came out of retirement to help VDH on the COVID-19 response. Carol Jamerson is a nurse epidemiologist with VDH's Healthcare-Associated Infections and Antimicrobial Resistance Program, and is an infection preventionist with 25 years of experience in board certification in infection prevention and control. We have 4 separate speakers today. Our first speaker is Dr. Jeff Morrison. Dr. Morrison is with the Tidewater Physicians and is a board-certified obstetrician and gynecologist through the American Board of Obstetrics and Gynecology, and has nearly 20 years of experience in the field of obstetrics and gynecology. Our second speaker is Dr. John C. Ring. Dr. Ring has decades of experience as a trained pediatric physician and has served as the president of the TNAAP and is actively involved in pediatric state and national level issues. Dr. Ring is retired from clinical practice and serves as VDH's Medical Reserves Corps volunteer and actively shares his knowledge with practicing and retired providers. Our penultimate speaker today is Dr. Omar Abubakar. Dr. Abubakar is a maxillofacial surgeon specialist in Richmond, Virginia, and has decades of diverse experience, especially in maxillofacial surgery. He serves as a professor at the S. Elmer Baer Chair for the Department of Oral and Maxillofacial Surgery at VCU School of Dentistry and VCU Medical Center. Our final speaker today is Dr. Mishan Bechamp. Dr. Bechamp is an internist physician partner at Selma Medical Associates, Inc. in Winchester, Virginia, and has decades of experience with providing primary care in the office, as well as acute care in hospitals and post-acute care in residential and skilled care facilities, along with special focus in weight loss, successful aging, and palliative care. And with that, I'd like to turn it over to Dr. Wozencraft.
Hi, thank you, Hector, and welcome everybody to all our participants, and a special thanks to our presenters today. Before we dive into the presentations, we're going to take a quick moment to review the Virginia case report data. This was updated yesterday, and we're continuing to see similar hotter areas, primarily Northern Virginia, Richmond and its surrounding counties, and some in the southeast. A few emerging other areas, not sure exactly what's happening over on the eastern shore, and then we see another slightly heavier area around Roanoke. Next slide, please. Well, so the good news with all of that is that while cases are, of course, increasing in some areas of the nation, they continue to decrease in Virginia. With the caveat that we may be a week or more behind in presenting this data due to time lags of testing and just compiling the data. Nonetheless, good news, the 7-day moving average continues to decline, and we'll look forward to continuing that trend, we hope. Next slide, please. So Today's format is less along the didactic lines and more trying to engage some frontline providers who have been dealing with COVID-19 in their specific populations as described previously by Hector. We're going to have a few brief opportunities to do some Q&A along the line. Since we're pre-recorded now, the Q&A will not be happening in real time to additional questions that are presented, but those can be answered in follow-up. And I'll get back to that at the end of the presentation. Then we'll have a brief case scenario from Dr. Béchamp, and we can follow with more Q&A. Next slide, please. So we're going to start. I am hoping that Dr. Morrison is back on. It looks like he is. And Dr. Morrison, as mentioned, has a lot of experience in OB-GYN, and we're looking forward to hearing some of his specific experiences and lessons learned with the current COVID-19 pandemic there. Dr. Morrison, over to you.
Yes, sir. I apologize for that. I was just finishing up.
Not at all.
You need video or no video, or doesn't matter? There you go. Anyway, I'll come on video. You were muted, so I couldn't hear you. I appreciate the chance to collaborate with everyone. What somebody asked me about, what I talk about how COVID is in our area. So the area of Virginia I practice in is southeastern Virginia, so the peninsula, Newport News, and Hampton. And we also have offices in Gloucester and Williamsburg. But the main hospitals we work out of are here, Sentara Careplex in Hampton and Bon Secours Mary Immaculate in Newport News. I assume I probably don't control the slides. Thank you. So COVID-19, obviously it's made a big impact on all of us. I took my mask off before I came on here. So when we had previously with our experience with SARS and H1N1 is pregnant women and frequently in respiratory illnesses in pregnancy, they tend to be very impacted significantly, as you see from my slide. So a lot of people with the bird flu pregnant women were frequently the ones who were hospitalized and intubated. But so far with COVID-19, we have not seen that kind of outcome. Patients tend to do well, and I'm talking now globally from literature review and American College of OB-GYN and the Society for Maternal Fetal Medicine Specialists, looking at kind of the recommendations they're giving us and what the experience has been. So far, we don't have any suspicion of vertical transmission. There's been a lot of stuff coming out of China, which has called it into question, but we haven't been able to, we've had babies being born and then being infected, but when they go back and test the maternal fluids and the placenta, and this is a mom who's pregnant with COVID-19, they don't find it in any of the maternal testing. And then there have been a few that didn't get tested, so it's kind of left us we're not sure yet, but it doesn't look like vertical transmission is the case, and that wasn't the case with SARS or MERS. I listed the ACOG and the Society for Maternal Fetal Medicine algorithm. It's kind of and I was thinking more from our outpatient perspective, like how do we approach it? I know there's so many recommendations out there, and this is a little bit of a divergent, I suppose, from like CDC. I was talking with our medical director. I put down there, like, if a patient comes in and we test them at 38 degrees or higher with a fever, then we would, that kind of alerts our concerns. He was telling me that 99 degrees Fahrenheit has been used in some of these algorithms, but this is the one from ACOG and MFM Society. And then just similar to the other screenings that we do when we ask patients prior to entering the office. So if you can go to my next slide, please. So then our experience has been limited as far as patients actually being sick with COVID-19. And I would tell you that I work at both hospitals in the medical leadership, and so I get reports on the total number of COVID-19 cases in our hospitals, and it's been very low, which thankfully for all the mitigation attempts and everything else, fortunately we're lucky in our market right now, and I hope that continues. So what we do in my office is, when we all come into the office, everyone checks their temperature. We're educating our staff, like, hey, we're asking patients, if you're not feeling well, like, identify that to us. If you have any symptoms, identify that. And then and then we take our temperature. I think we've had one employee we sent home for a temperature. She ultimately felt fine, and she was COVID negative. Then when it comes to patients, we ask all of them these through multiple formats. When we call them on the phone, we ask about any of these screening questions. We also have a couple of different online check-ins, and they include that same screening list of questions. And then, so that's been good. And someone screens positive ahead of time. In our electronic medical record, people can check in ahead of time. And if they check in ahead of time, a couple of days ahead of time, even to say they're planning to come, and they screen positive, we get notified ahead of time. And then our medical director across our company reaches out to the site, and then we contact the patient to kind of further clarify. That's been helpful. It has been it's interesting because some of my patients are friends, and TPMG's not just OB/GYN, but we have a multi-specialty group with 200 providers. So a lot of my friends also see our physicians, and they're adapting to this new reality and really well. And one of them, I was with them this weekend, and she even said, and this will be relevant in a second, waiting in the cars, she loves it. She's like, I hope you never make me come to the waiting room again. I love being able to sit in my car, and then you text me or phone me, and then I come to the door. She's, I'm not ready to turn my waiting room into another place to see patients, but it's interesting to see how we are adapting as a society, as in our patients. So that's what I'm describing. So we tell patients to wait in the car. We have multiple, our electronic medical record and one of our FREESIA is what it's called. We do have a two-way text, HIPAA compliant text and communication capability. So we just have them wait in the car, and then we text them when they're ready to come to the front door. And in most cases, that's fine. If we do have to have them wait in the waiting area, we have everything socially distanced to do that, and it's been well received, as you can hear from me. So one of our MAs was COVID positive. She didn't feel comfortable. I think it was a home acquired infection from her daughter, and came in. She was positive. She felt bad. We didn't pick up that she had a fever the day she came in. But we all are wearing our masks. She's wearing a mask. So then when it was positive, we reported to the health department. They reviewed it. They said, we advise you to stay home. However, you guys are essential personnel. And if you need to, we feel like you should come back to work. But everything was reviewed with the health department through our medical director, and everybody's very helpful, and she's fine. Thank goodness. We're working electronically with virtual visits. So she was able to continue to work. And we've had nobody else. We screened everybody twice who was close to contact with her, and no one else has come back positive. So far so good, but it was definitely a little bit of a scare. Next, I'll talk about the next two slide I have, talking about my experience at the hospital. So it turns out right now for another year more, I'm the OB/GYN department chief. So we have a lot of conversations around this, and it's interesting because the two hospitals are interpreting, or not interpreting, they're choosing to approach laboring patients a little differently. But both hospitals do this consistently. I went in last night to deliver a patient, and I get screened when I come in, and they give me a sticker saying I've been screened for the day. And then they hand out masks, and all the staff are wearing masks. And we screen all the patients get screened with a temperature check, and then the questions about any symptoms. We've had nobody. We've screened people. We've had people screen positive in the questionnaire and then not be positive. We've had no COVID-19 positive patients admitted to the Immaculate labor and delivery. And then the Immaculate has chosen to any elective case to screen those patients prior. And then we also anybody who was going to do elective procedures like we do in OB/GYN, we all had to be screened. And once we had 2 negative screenings, and the first one was the oropharyngeal, the second one was just the pharyngeal, but it was a little bit of a chance to live like my patients to see what that feels like. But I don't wish it upon myself again, but it's hard when you don't feel bad to get screened like that. But I'm sure when you feel bad, you just want to know what's wrong. But anyway, so we had 2 providers at Mary Immaculate along in the surgical area and the L&D area that screened positive with no symptoms. They did not turn positive with antibody testing. But so anyway, there was a little bit of people a little bit disgruntled with that process, but it it seems like it's worked out well for us at the hospital despite that. And then, as you read through, what do you do if you have a staff person who's pregnant? And we currently at Immaculate, they just, if that anybody, someone suspected of COVID or COVID positive, they do not allow the pregnant staff to work with them. The guidelines across like ACOG talking about when a woman is pregnant who's a healthcare provider, when she reaches 37 weeks, that they recommend self-quarantine and not working to try to avoid that potential risk. And I'll explain some of that when we go into what you do with the woman who is positive after they have their baby. The next slide is what my experience at the Careplex, which is the other hospital I work at. Same, they're both very identical in the way they approach visitors to the hospital, staff, visitors, patients, and both hospitals also have a restriction of one person who can come to the hospital during pregnancy, and they have to remain in the hospital. They can't come and go. Both hospitals on that. It's led to, we've had a few patients who've opted to transfer care to like one went to Richmond for a birthing center that wasn't as restrictive and allowed a doula to attend the delivery. We've had a few opt to deliver at home. We caution them about trying, the risks of that, and try to just give them good advice on what to do. So that has driven that the visitor policy at both hospitals has driven people to choose other alternatives. There's been one COVID-19 positive patient at the Careplex. She didn't have any prenatal care, asymptomatic, no problems arose. And then again, in contrast to Immaculate, the Sentara's facilities, everyone 100% screening for people who are coming in to either elective repeat C-section or inductions. And then those patients we screen ahead of time. Patients who come in labor are screened, and that's been the approach. I think overall, this, as I said, as I started, we just, fortunately, and I hope it continues, we just seem to have a low incidence of COVID in our community. And for all the reasons that are working, I hope they continue to work, and hopefully other places will adapt some of the ways we've approached it across our state to be successful. Let's see the next slide. I did reach out to Dr. Alfred Abu-Hamid, who's an MFM specialist in Sentara Norfolk General. They provide consulting services, and they cover all deliveries for the residency program at Sentara Norfolk General. He initially said 5 to 10 positive patients, so I didn't really want to put 5 to 10 on the slide, but I think he ballparking his opinion of what's gone on there. They do the same thing as all Sentara facilities, 100% screening, and he thinks it's about a 2% incidence reported of COVID. No significant illness, fortunately, across all the facilities that the two I had to work at in his facility. The next slide I wanted to talk about. So one of the things one of those things has also got a little bit of a varying recommendations depending on who's sending out the recommendations about what to do with the mothers. And so the challenge for us in OB, obviously the mom's COVID positive, the baby's born. We don't think there's vertical transmission. There is droplet transmission risk, but the harm, and this is where I fall on the side of the mother and the challenges that mothers and babies have with potentially with bonding and postpartum depression and just and what the effects might be on a child that isn't closely bound to the mother at the beginning stages of life. So the ACOG, WHO, they have not recommended this separation. They've recommended caution, but not separation. Where CDC and the American Academy of Pediatrics basically said, hey, you should definitely have separation. And they still encourage breastfeeding, but they do want to have basically social distance between mother and child after birth. That is Bon Secours, Immaculate. We haven't had to encounter that issue at the Careplex. They have not. They did do that with the one patient I mentioned. They've had a few patients, knowing this is their policy, refuse testing. And if someone refuses testing, they haven't imposed. They have not imposed the separation. So I hope, I hope that we get to. Obviously, we all hope we get more knowledge. It's just hard for me to think about a mom having a child and then telling her, you're going to have to, your baby's going to have to stay away from you for a period of time until we know you're not able we're not worried about transmission. And then, you know, moms and babies don't stay in the hospital as long as they're well in a very long period of time. So part of me, the rationale is like, you know, I don't know how we would enforce this when they go home, where I don't think it's realistic. So, but I, you know, hopefully all of it comes down to, in medicine, you know, we just have a discussion with the mom, both pediatrician and obstetrician. Hey, here's kind of what's going on, and here's what we're talking to you about. Here's what we're concerned about, and then trying to make a collaborative decision that we feel like is safe for everyone, with all things considered. And then further on in breastfeeding, it is, no matter what the separation or not separation, there's so much benefit from breastfeeding. So it's highly encouraged, with no matter what's going on in patient care. And you can see that what the recommendation is, that please try to breastfeed. We don't think that's a transmission risk. You know, if there's a high risk of transmission, use a pump and use a bottle to breastfeed. And then if you are going to directly breastfeed, just try to avoid that transmission from the mother to baby. Let's see, I have one more slide, I think. And then, you know, so I looked this up just to see, like, what we have not had to, thankfully, experience this in our hospitals I work in. But it does look like that, you know, it doesn't look as extreme in the neonate, and that fortunately, so I hope that as we get more information, I hope that persists. But so again, back to what do you do with the mother who's COVID positive with the baby? So I think it is, unfortunately, if the baby does get sick and gets, you know, it's a challenge. But apparently, so far it looks like that incidence not too high. So I believe that's my last slide. And then I don't know if there's any, I'm not sure the format. I'm sure there's maybe not questions, but I'm happy to answer questions. But.
Well, thank you. That's really great to hear that things are going well. I would quickly make a couple notes based on what we've heard in previous presentations, that it sounds like you've really gotten the workflow and patient flow and pre-visit issues pretty well addressed. And that's fantastic. I guess my quick question before we do move on, and I know you have to get back to your patients today, but it would seem that the future of antibody testing certainly is put at a premium in terms of potential maternal transmission to newborns, and even vice versa if there's no immunity. Is there anything emerging on your end from that?
Yeah, no, that's one thing I didn't look at. You know, it's such a unique time for all of us. So one of the ladies who works with me at TPMG, she's our lab director, and she's also the medical affairs vice president at Mary Immaculate. So we've talked about it frequently, and I'm just talking more globally about the testing. And she's saying, if, you know, she feels stuck because she wants to apply science, and she did her med tech training in college, and she's like, if 5% of the population has been exposed to a coronavirus that could have antibodies that might show up in this test. So I'm not answering your question directly, but I mean, it would be huge if we knew more about it, but that, in my understanding of the current test, I'm not sure what it gets us, you know, with that, if there's a cross-reactivity potential, or it's just, I will have to, I apologize, I haven't looked to see where we're headed. We haven't done anything with that currently, and I think maybe we're just waiting on a confirmation that the test is accurate and could be actionable.
Yeah, thank you. I think we'll all stay tuned on that. Thank you so much.
Yeah.
Excellent presentation. We really appreciate it.
Yeah, I saw there one question did pop up. First trimester, any practice guidelines with this category of patients? Recently had symptomatic COVID. Oh, okay. You know, I think as long as they're not currently, currently sick, I don't know that we would treat them any differently. I think it's, I don't know that we do anything different, to be honest.
Okay.
All right. Well, thank you very much.
Thank you very much.
Yes, sir.
Could I have the next slide, please? Or gosh, we're already there. So we're going to go over to Dr. Ring now, and we're looking forward to hearing some of your experiences and those of your colleagues among your pediatric patients. Welcome, Dr. Ring. Dr. Ring, are you able to hear us anymore?
Can you hear me?
Yes, thank you.
Good. Just as an aside, I hate these machines. In addition to the reiterating the disclaimer that I do not have any conflicts of interest, I want to emphasize that the person I'm speaking for is actually myself. While I have held and currently do have a leadership position within the Virginia chapter of the American Academy of Pediatrics, I'm not speaking officially on behalf of the chapter or for the national AAP. Lisa suggested a number of questions that might be posed to which I could answer. And so I'd like to lead off with the first one. Persons who care for children at home, and I'll subsequently refer to those persons generally as parents, have identified that they feel unique responsibilities during this pandemic, responsibilities that in turn have heightened their stress. I think it's important that providers recognize the stresses there and that they respond empathetically to those persons' needs. And for me, that response begins with information and education. I think there's 5 communication points to emphasize. First, this is a novel infection, so our evidence base is both incomplete and it's rapidly evolving. I really think there are only 2 things that are certain right now. What we know will change with time, and we will make mistakes, albeit with the best of intent. Providers and patients need to identify trusted sources of information, then attend to them, and then screen out the noise. And there's a lot of noise in the environment. Second, the current epidemiologic and clinical data tells us that infection in children is less common than in adults. The infection is similar in type, but usually less severe, with the infection of the multisystem inflammatory syndrome in children that's been recognized in a number of places around the world. The risk of transmission from children to others is also less, but that evidence is not conclusive enough to really help us form policy. As with adults, there are some children who are at increased risks. Infants are, though not neonates, fortunately, and children with pre-existing conditions, amongst which is obesity. The social determinants of health are just as important for children as they are for adults, and disparities populations therefore require special attention. Third, mitigating factors remain the mainstay of minimizing transmission, and they include the things we know about: proper hand washing, physical distancing, which is becoming the preferred term over social distancing, covering coughs and sneezes, and avoiding high-risk encounters. Current guidance recommends the use of face coverings, despite the fact that they are limited in the protection they provide. Masks should be used in addition to, not instead of, more evidence-based mitigation. And surgical masks, in particular N95 respirators, should be reserved for professional use by healthcare providers. The AAP has made specific recommendations about the use of face coverings in children. Note that under 2 years of age, face coverings should not be used at all. 4, the respiratory transmission route is far more important than the environmental. New evidence suggests that respiratory transmission by aerosol versus droplets poses the greatest risk of all, and that has implications as far as mask use is concerned. 5th, the worst is likely yet to come. Currently, only about 5% of the US population has been infected. And barring the impact of a vaccine, deployment of which realistically is many months away, 60 to 70% of the population will need to be infected for us to develop herd immunity. And the duration of that herd immunity is unclear. The second question, what should parents do regarding congregate care settings if they think their child is sick? The simple answer is if your child is sick, they should stay home. But experience teaches every provider that this often is not the case. If you think a patient of yours might have COVID-19, the parent or home caretaker should call you before they come to the office or go to the emergency department. Moreover, if they think the child is critically ill, they should call 911. School means many things. Most parents believe strongly in the value of education, and they may be quite uncomfortable with supervising homeschooling. The impact of virtual school, moreover, is not established compared to more traditional modes of education. Parents may have a strong incentive to return to work, something that is impossible if they lack childcare during working hours. There is a recent Census Bureau study that documents childcare responsibilities are associated with caretaker job loss in over half the families who have one or more children under 18 years of age. School may provide essential nutritional support. And finally, school may offer a safe haven for children living in violent home or neighborhood situations. It's important, finally, I think, for us to recognize that guidance, no matter how trusted or evidenced the source, never supersedes applicable federal, state, and local laws and policies. Therefore, it is crucial for daycare providers and for schools to work with local stakeholders, tailoring their plans and actions so that they are appropriate for their community's level of transmission. The governor has provided for that in his executive orders, but those necessary stakeholder relationships aren't necessarily established, at least to the degree that they need to be. Finally, I think that we all need to foster an enhanced sense of personal responsibility for any congregate activity. The third and fourth questions that Lisa posed to me, I combined. How should parents parent during the pandemic? That sounds like a tongue twister, doesn't it? The AAP has established goals in its communication parenting in a pandemic. Those goals are help children feel safe, both physically and emotionally, maintain healthy routines, manage behaviors, both good and bad, and build resilience. This really is public health crisis communication made age appropriate, and its elements include several. Reassure the child they will get through this, and so will their family, but be honest about what you don't know and admit it. Validate the child's feelings, whatever they might be. Address their concerns specifically. Model appropriate behaviors yourself, including self-care. And in particular, detail when and why you might be unavailable to the child and for how long. Include children in problem solving wherever that's appropriate. Help children keep in touch with those friends and family members they cannot see face to face. Minimize physical discipline. Redirect bad behavior. And be patient. Not everything is a go to the mat issue. Finally, create more opportunities for family time while still providing each child with some one-on-one time as well. To some, I think it's important that we be predictable but flexible. The fifth question, how important is routine healthcare maintenance in the era of COVID-19? The simple answer is it's essential. Dr. Redfield, the CDC director, got into trouble in April when he raised concern that we might face a second wave of the novel pandemic this fall, compounded by seasonal influenza. If you pile on top of that outbreaks of vaccine-preventable disease, that would create a perfect storm of infection, something that could once again threaten to overwhelm not only our healthcare system, but the entire society. is there any evidence that we should worry? Data from the Virginia AAP documents a 25 to 35% decrease in routine immunizations. And remember that seasonal influenza immunization rates are always poor. Data from CDC documents a decrease in these routine immunizations up to 60% nationwide. Data from the World Health Association is similar, and we cannot feel safe that whatever is happening in the rest of the world doesn't put us at risk here in the Commonwealth. The periodicity schedule is important to maintain, and it's there for a reason. Pediatricians have as their overriding goal maximizing the full developmental potential of all of their patients. Third reason, pediatric patients, like adults, have chronic illnesses too, and routine healthcare maintenance for them is just as important to help keep them as healthy as possible. The fourth reason, reestablishment of the healthcare routine may be essential to maintain the viability of pediatric practices. There is a Commonwealth Fund study that documents a 60% decrease in routine visits that's been only partially compensated by an increase in telehealth encounters. And pediatric practices have been particularly hard hit by this decrease. Virginia AAP data shows that Medicaid visit volumes and compensation have decreased by at least a third over the last 3 months. Finally, it's important to reestablish the healthcare routine so as to maintain the medical home, something that's absolutely fundamental to pediatric primary care. Fortunately, thanks to pandemic-induced changes in workflow, pediatric offices are amongst the safest places to be outside of the home. Providers, as Dr. Morrison showed, are doing their part to balance the risk-benefit equation that's part of every clinical encounter. But parents need to understand with our help that there's no intervention that's risk-free. Lisa had asked me to be prepared to comment on what retirees might be able to contribute. In particular, the value of belonging to one's professional organization and the importance of going outside your comfort zone, which for me is into the world of advocacy. And I'm prepared to do all that, but I think for time's sake, I'm gonna bring my prepared remarks to a halt right now. And this is something we can pick up if there's interest in the Q&A.
Dr. Ring, thank you very much. I think you're really, kind of hitting the nail on the head that we all realize this is a perfect storm and hopefully not going to get even more perfectly stormy. So thank you. I would like to now try to move on for time and come back, as you suggest, to some of the issues that you've brought up toward the end of the conversation if we have time. So next up, we're lucky to hear from Dr. Omar Abubakar, who, as you heard from Hector, is an oromaxillofacial surgeon. And we know from other sources that dentistry and other high face time areas are particularly impacted. Dr. Abubakar, over to you.
Thank you, Colin. If you're just curious, that's the new me. That's the picture of new me. I'm reflecting, I'm adaptable to the new change. And so that's the real me. Real me is this one here. Also, I changed my name to, can you hear me now? I changed my name and I changed my look, just so I could prove that I'm adaptable to the environment. I have nothing to declare. I have some slide that one or two slides that I used from a presentation given before by other speaker in our community of oral surgery. What I'm going to talk about is a little bit more, maybe a little bit different in some ways than that the word physician, but in other ways we're all in the same in this. I am in an academic environment in a hospital setting, a large medical center. So we have a lot of policies that we followed, even though we're in the dental community or the dental ward, but most of the stuff related to following the procedures and the process in a hospital. I'm going to talk about it in two phases. The early phase, which is when we first find out or first got into Virginia, we watched New York, and it's like it's not going to come down from New York. It's just in New York. And then before you know it's in Virginia. And then what do we do now? And the first thing is like everything else, fear. And I say unlike past fears, meaning that before, we feared that we, get infected from the patient. But I think the truth is that patient also have fear of getting infected from us. So this is unlike any fear. Also, I'm old enough that I lived in the times of when AIDS first came out, HIV. And I remember vividly that we just didn't know. All we knew is that if you get infected with HIV virus, you're going to die. Same thing here. If you get infected with COVID, there's a good chance you can die. I think there are similarities and there are differences. But for those of us who lived that era, kind of brought back some memories and some maybe past experience. And I'll talk about how we went through the acute phase, the fear and the anxiety and what to do, and they're all changing daily to where we are now. And I'll try to do the next slide, please. Next slide. So the background of the dental side, aside from physician, that all, I say not all, but majority of dental offices closed. Some remained open for emergency care, very few. A School of Dentistry that provide extensive dental care to the community and to the Commonwealth closed because of regulation by the state that the students and residents cannot be exposed to, harmful process or virus during the learning. So they closed. It was limited to triaging patient into either to our clinic in the hospital, which is the oral surgery department, remain open, both the hospital and dental school. But dental school, our clinic is closed. The building is a dental school, a university, so that closed. But we have a clinic in the hospital remained open, and we let it be known that we're open for the care, not only for people coming in from the dental school, our established patient, but people coming from the ED and people coming in from the community and coming to the Commonwealth. And so you would imagine that tons of patients coming in because there is no care outside. And the reality is that I think the fear among patients kind of limited the number of people, but we still became the kind of safety net for the population of patients who have dental care that could not be delayed, meaning like you have a toothache that you just couldn't sleep the night before. In fact, we came to a point, tried to estimate what is, your grade of pain from 1 to 10. And if it's 1 or 2, we said, we'll prescribe some non-steroidal, non-narcotic. And if it's higher, then we may bring you in to check on you, or at least maybe do the extraction of the tooth. We didn't do anything other than extraction. It's emergency care. People that maybe need a root canal to relieve the pain. We don't do that. We don't have a dentist to do it. So that was referred to the community by the dental school. Next slide, please. So against that background, we have to remain open. We have to allow people that were open. And we met as a faculty and as a department and residents. And I made sure that this is a new ward. We're going to close the elective care. We're going to go forward now with a new ward, a new strategy, new goals. And we try to articulate that and set ways how we're going to get to it. And one of the most important things that I learned, both from the leadership in the hospital and from my own experience, is that we have to communicate because there is so much unknown, there is so much anxiety, there is so much fear that I made a weekly meeting, Zoom meeting with my faculty, weekly Zoom meeting with the residents, and weekly Zoom meeting with the staff. So we update ourselves, we check on each other, and we tell what's new, and bring information from the command center in the hospital and share it with it. I think that is really a good, I find that one is one of the most, learning process that I learned, and I found brought me closer to my residents and faculty and staff, and brought me closer and alleviated some anxiety meeting on a daily basis. But also importantly, let's check on next slide, please. Next. And we decided that we're going to restrict procedures only to elective procedure. What we talked about early on is that, listen, this is an infectious disease, and unlike any other infectious disease, this is a contagious disease, unlike contagious diseases. And this is unlike any other disease that we know about. So really, there are a lot of unknowns. And we know one thing, that there's no good treatment for it. So we figured our best bet not to die, or not, infect our patients so they die, is to prevent. So that's the strategy. That's the only thing that we could have in our hands. That's the only tool we could use, but we're going to try to use it as often as possible. Next slide, please. Because early on, there was no testing. So we didn't know, in our medical center, we didn't have testing in the first few weeks. So since there is no symptoms and people who who are infected, we can assume that not only all patients are infected, but all staff and all faculty. So everybody's infected. And the best thing to do is assume that, so we could work backward from there for safety purposes. Next slide, please. And I think, next slide. So to add to it, dentistry and ENT, of course, are one of the highest exposures. And the hospital indicated that anything that is aerosol creating procedure, which is every dental procedure you could think of, I mean, not using the drill on every patient, but we're using the suction. And they said using the suction in patient mouth, you create aerosol, and you create aerosol, then you high infectivity area. That means not only you're working in a high risk area, but you're doing high risk procedures. So this is another layer of risk that we exposed to as dentists and our colleague ENT. And that meant that philosophy of prevention is the only way for us not to get infected. Next slide, please. Articulated to my faculty and residents that I said, we have to provide the care because people cannot put a toothache another day. So this is not something that we cannot do or we have to put off for another week or 2 weeks. So patients who are in pain are going to be taken care of. And we committed ourselves to patient care, so we cannot abandon this patient. But in the meantime, we have a social responsibility that we do not spread the virus. And you spread the virus, meaning the patient infect us or infect the providers, and vice versa. And it's all possible that we could infect the patient. And I think everything that we do, it's just two ways. It cannot be just the fear of patient infecting us, but also the fear of infecting. That becomes clear as I go into the presentation. That becomes clear that patients have to feel safe because it's important that we convey to them that is not just the mission of us taking care of them, and not get, the fear is both ways. Next slide, please. And go back to one slide. So that meant the safety accepting or adopting a safety culture. It has to be universal for everybody in the area. Patient safety, doctor safety, provider safety. That's the principal guide. Next slide, please. We articulated that and we said, so, like I said, for those of us who lived in HIV early days, we use the word universal precaution. So that means we assume that everybody affected or everybody's at high risk until proven otherwise. That word just came handy, even though we've been using it on a regular basis and our practices since the HIV and since the hepatitis, especially for dentists working in patient mouth. But I think now it's back again very forcefully. Next slide. Right. And from many of you know this from safety processes, that's a Swiss cheese. So for that safety, we have to put many layers to prevent the virus, so to speak, from getting to us. And I think, to that extent, next slide. To that extent, the layers, and I told the residents and faculty, if every layer reduces by 1%, it's 1%, one person not getting infected. Limiting procedure to emergency, that's one layer, so we don't have to spend a whole lot of time in the mouth doing an hour or 45 minutes. Screening questions for pre-arrival and arrival, checking temperature. All must wear masks, patients, staff, and residents. Social distances, secure, PPEs, and a structured scheduling, meaning that patients are not accumulated in the room. We have distance of 6 feet between chairs in the waiting area. And if the waiting area is full, we need to tell the patient to wait in the car like we previously said. So this, we figured, there is a possibility that of all this, we still get, maybe some that escape the safety. But the more layers we add to our safety, the less likely we get infected or a patient get infected. Next slide, please. And this is kind of a guiding principle for me that, of course, use telehealth, that we have patients screened sometimes beforehand, so we know what they're gonna have, and we plan the procedure before they come in. Sometimes they have an x-ray, sometimes they don't, but we have a lot of information, so their time in the dental chair is shortened. The history mostly taking all the symptoms, so basically early on, that process or the time that we spend face-to-face with patients is it's much shorter. Next slide. These are the questionnaires. You're familiar with. I'm not going to go into the detail. Next slide, please. And I'm going to go through this. Really early on, what I emphasize to our residents is the adherence to adequate PPEs. And we early on before the testing, we've taken even some patient to the operating room, but we have N95 in our clinic. The residents wore the N95. Next slide, please. The residents wore the N95 and were not to consume a lot of PPEs early on because we're short on it. We have the residents wear masks over. Next slide, please. So these are kind of really the things that we stuck to more often. That's a list that we really don't use much of it. Basically, we have N95. When we're doing a procedure, when we're doing the exam, we wear surgical level 3 mask, face shield, gown and gloves. Those are essential for every patient when you walk in. The N95 would be when you're doing a procedure, the surgical mask, and we'll wear surgical mask, and you replace the surgical mask, and you keep the N95 for the entire week. Next slide. We also have, this is a kind of facility engineering that you're probably all familiar with, so I'm not going to spend detail into the next slide. These are all safety layers that dictated, recommended by the hospital into different areas. We didn't have filtering, but we have environmental cleaning for the room. We have time between procedures that the rooms let to settle, so the aerosol droplet will settle, allows about half hour to 45 minutes between procedures. This is early before the testing phase because we assume that these people are infected. If the case is long, it's going to take much longer than a half hour. We've taken it to the operating room. Very similar PPEs, but the protocol is the same for our room as the operating room. The only difference in the operating room, some of the procedures take longer. And some of the patients came in, by the way, we continue to do the trauma, facial trauma, do the infection, things that major cases that came through the ED, we took them to the operating room. People came in for a toothache, came into the office or the clinic. Next slide. I think for me, the sad reality is that the virus is here to stay and probably stay here for a while. And there is no, for the foreseeing future, it doesn't look like there is a specific treatment. I just heard that dexamethasone, yesterday, dexamethasone reduced the risk of dying from, I think, by 30% in some patients, by 20% in others. This are all, I think, Band-Aid and I think temporary things. And I think to that extent, we just need to figure ways. But to me, the most important part is reaffirm our mission that we have to provide care. We switched it now in the last 3 weeks. We provide elective care, but we continue to use the same measures and learning experiences that we learned from the early phases: safety, commitment to social distancing, commitment to social engineering, all the other things that we learned in the acute phase when we didn't have a test. We're doing them now. And the strategy is prevention, safety model. And right now, what is new once we get into the elective care is some patients don't want to come in. If they're going to have wisdom teeth or you're going to have a minor procedure or dental implant, they said, so we have to address the fear, patient fear, provider fear. I think we got over it to some extent. By the way, now we added testing for for oral surgery only, but not for dentistry. Dental school still have it, all the other models or all the other strategies, but for oral surgery, we follow the hospital for all pre-procedures that are high risk creating aerosol in the oral cavity. Patient has to be tested. We get people to test 2 days before. If they test positive, then they postpone the surgery if it's elective. We'll do the surgery in the operating room if it's an emergency. But if they're negative, we bring them in and do procedures like wisdom teeth or extraction or implant. Next slide, please. Again, we added another layer, like I said, in our practice now, and I suspect as we go along, we add more and more layers to, more slices, I say, to the cheese. So testing now, pre-procedure testing is part of our protocol, specifically in the oral surgery department. Really not necessarily mandated by the ADA, American Dental Association, or by Virginia Dental Association. If you wear the proper PEs and you do the other things, they feel that it's safe enough up to that point. I think it is, but I think if we have access to testing, like I said, if I could add the testing is 97% accurate. So there's still 3% window. And I made it here because I think there's still, despite the testing and the PPEs, there's still that risk. The risk is not zero, but I'm trying to drive it from my department, my residents and faculty, to be as close to zero as possible. Now, testing is only one of those things, but I think every creative way I could add to prevention of the disease is obviously minimize or get you closer to 100%. I kind of doubt that our risk of 100% until we warranty ourselves from the grocery store, from everywhere, it's not going to be 1%. It's not going to be 100%. Next slide, please. These are our hospital. As we relaxed, we came up with, the hospital came up with the new regulations, and you've seen this before. There's a red zone, whereas the high-risk areas, this is mostly the ICU, the COVID positive patient who need to go to the operating room. There's a specific room in the operating room that's in the operating theater that's dedicated toward patient who COVID positive. And there's yellow areas, which is the rest of the hospital. And there's, of course, the hallways. And so this way we could use the PPE, because the PPE initially is everywhere. Everything's infected. Everything is risky. And now we kind of relaxed our criteria, and we came up with a little bit more realistic expectation of what should we have in each area. Next slide. That's the time we're in now. I think what I need to add specifically to the dental side is that, and I suspect the medical, because my medical colleague told me that some of the patients are not coming back. And you could see that a lot of people in dentistry are not coming back. It used to be 1 in out patients, 5, now 5 patients are comfortable. And I next slide, please. I have one of my friends told me that the dentist called her and said, your appointment, by the way, is now for 6 months, and we're open, and if you want to come in. And she said, I asked them, so what are you doing to keep me safe? This is an educated person. And they told her all the things that to keep the doctor safe. And she said, tell me again, I'm asking you all the things you're doing to keep me safe. And of course, the clerk person didn't know the answer. Reality is what keeps the patient safe is probably what keeps the patient safe. But I think the messaging has to be that here are the things that we're doing to make you safe, and we have worked on the things to make us safe. So we're all safe in a safe environment. I think to allow people to come in, I think that's what we should teach our front desk people to bring patient back, is emphasize their patient safety rather than our safety. Our safety, obviously, it's our own business, but their safety as they taking care of their own, or they worry about it themselves, but it should be our business as well. Next slide. So, clearly, we have to continue to provide oral care, even though it's a high-risk oral surgery area or oral cavity dentistry is high-risk procedure. It's not going to go away. The virus is not going to go away. I think we have to keep in mind, we swear to the oath that we don't hurt our patients, so we don't compare our patient. Really, we have to change. And I think the most important part for me is that I learned in the last 3-4 months more than I learned in the last 3-4 years about something that I never even knew existed. And I think we should use that learning experience, just like I used my learning experience from the HIV toward this virus. I think we should learn this experience as to going forward and doing the things for, this is not going to be the last virus that's going to come in our neighborhood, you know? So I think we should be prepared for something, you know, hopefully the generation, our generation, hopefully not going to be in seeing another virus is bad, but this young generation that are coming in now that they were not exposed to the environment of HIV in the early phases, they would use this experience in the next virus. Thank you very much and for giving me the opportunity to share my knowledge with you, and I'm honored to be in the company of such a distinguished speakers. Thank you.
Thank you, Dr. Arbebacher. That was fantastic. And I think that I'm going to try to move us along quickly to Dr. Béchamp for her case. And we're just going to let it go over if that's okay with everybody. I wished we had another hour because I'd like to hear more from all of our speakers. But that said, we don't have it. So Dr. Béchamp, over to you.
Thanks so much. So I'm an internist, and I'm somewhat of a dinosaur because, one, I'm in private practice, but also I am a very traditional internist where I see patients in the office, the hospital, and nursing homes. And that's not a point of introduction, but it's also relevant in how we got the honor of being called the Scarlet Sea Clinic in our area. We were the first clinical setting to have a COVID outbreak. In terms of what our clinic looks like, it's an independent building about a mile from the hospital. We have 4 areas of practice. We have a walk-in clinic, we have a cardiology area, we have internal medicine, which is combined with infectious disease, and then we have a family practice area, and they're all separate areas, which is also relevant to how our outbreak occurred. We have about 16 doctors with about 12 advanced care practitioners, and then the support staff to go with that. So we see about 2,500 patients per week, which is during normal times, we're probably about 80% back up right now. So back to when we had the outbreak, it's sort of, I feel like I have to step into a time machine a little bit because it was only 10 weeks ago, but it feels like a very much longer time. So, Virginia, the emergency was called on March 13th. March 16th, we had an all doctors meeting. So we're all in a conference room talking about how we're going to address this crisis in our practice. So about 14 of us met. A couple of them are out on maternity leave. They dialed in. So we were sitting in a conference room and violating the state mandate not to have more than 10 people in the gathering. And during that time, you have to remember there's a short supply of everything, including cleaning supplies, masks. Patients were stealing sanitizer from our rooms, and so we ended up having to lock up those and going back to soap and water for everything and not being able to use alcohol wipes or hand cleansers. And at the time, also, the only screening things for COVID were cough, fever, shortness of breath, and travel to a hot spot. So we had that meeting March 16th. Our decision was to stop doing all non-essential visits, such as annual Medicare wellness visits, and trying to push out physicals. So we ended up seeing acute patients that week, including in our walk-in clinic. In terms of the nursing home visits, we were all still going out to the nursing homes. We were all still going to the hospital, and we were seeing patients in our clinic. We're also working on transitioning to telehealth, both with our malpractice carrier, as well as with state guidelines. We're very close to West Virginia, and so we had to be careful about seeing patients who are at home in their West Virginia homes and not practicing across state lines. Eventually, that restriction was lifted and retroactive. So anyway, all those things were in process. However, a week after our all doctors meeting, one of our doctors wasn't quite feeling well. She thought it was allergies. She couldn't taste, she couldn't smell. But she's like, okay, it's just allergies. She saw a full clinic that day. The next day, she rounded in the hospital, and that was a time when there was a no mask policy. They're trying to conserve PPE for those folks in the ICU or the people who are actually known COVID cases. And so she rounded in the hospital. And then later that night, she started having a fever. And she texted, she did sort of a group share opinion about should she go get tested, and everyone resoundingly said yes. And so she got tested, actually by one of the vice presidents of the health system, because that was really the only way to get tested at that time. You had to go through the hospital system. They did a stat test. They ran it in 24 hours, which was remarkable at that time as well. It was at that time when it was taking about 5 to 7 days to get test results. So anyway, so that one doctor came back positive. And then subsequently, several other doctors and providers started being symptomatic. And eventually, we had a total of 8 providers who were tested positive and symptomatic. We had one front office person, a person who's checking in patients, and then we had 2 nurses. We had several other people that were suspicious for being symptomatic, but not providers and not on the front line. And so within a matter of 24 hours, we converted completely to being a remote office. So we got phone lines set up at home for our nurses to triage patients and check them in. We all, physicians, providers, all retreated to their own homes, started seeing patients from remote sites. And so basically we quarantined the building. After that sort of initial surge of positives, we had one last nurse who was tested positive about day 12 of the 14-day quarantine. We were able to reopen mid-April in terms of in-person or on-site seeing patients, and we made some needed environmental changes in terms of separating people. So multiple people were in shared offices. We shared exam rooms, shared nursing staff. We came back sort of in columns. And so we separated offices, we separated exam rooms. And so you really had a bubble of people. You had one nurse, one provider, one room that you're dealing with. And since that time, since we reopened on this modified plan, we have not had any positive cases on our staff. Throughout this all, we did not have any known sharing of the virus with any patients. So even that 1 week, we were sort of scrambling to shut down and transition, pivot to being a virtual office. We did not have any positive patients. Those patients that the one physician rounded on in the hospital, they are quarantined in the hospital for 2 weeks. They were never symptomatic. So we're very fortunate. I'm not sure we can credit anything we did differently that they were not infected, other than it was a very brief interaction. Because again, as I said, at that time, no one was wearing masks unless you're actually working a COVID unit. So besides being both a cautionary tale about being so worried about who's coming in the front door in terms of screening patients, we forgot about the back door a little bit. But also, I think it's a lesson in hope in terms of seeing that some of the mitigation strategies are helpful. So after we had the outbreak, we did tracking. So as we were starting to reopen, the antibody test was available. And so since we have an infectious disease person in our practice, we had access to those. And so we started testing people who are not symptomatic but had high exposure risk. So for example, my office mate was positive, but I was never positive, and I didn't have antibodies. I was never symptomatic. And similarly, we tested the spouses of some of the symptomatic people, and those who sort of had the attitude of, well, we're in the same household, I'm going to catch it anyway. They sort of went about their normal business once they're at home. Those spouses and family members were actually had antibody positive tests, even though they were never symptomatic themselves. The families of those who went home and sort of holed up in one room and sort of quarantined at home, those family members were never positive. And so, as I said, the lesson learned is, one, seeing is believing, seeing that this can affect us, even though we're so concerned about our patients and taking care of those patients. We never transmitted it to our patients, as far as we know. There's been no reported cases of that. And seeing and believing about, our community of our office, it spread like wildfire. It was pretty significant. But what we also learned is that the mitigation effects work. So for example, we know more now that the time and type of exposure matters. And so we found that in terms of who it spread to, it was among those having extended face-to-face interactions. But it was not spread about people who shared an office. As I said, I share an office with someone who is positive, but our backs are to each other. We have our own computer. We go in and out the door at different times. And so in terms of that person-to-person spread, it really matters how you're interacting with that person. It's not just passing them or not even sharing the same ventilation system. We found that the masks are effective, where everyone's wearing surgical masks. We also found that it was very demoralizing to those physicians and those providers that were positive. I mean, they felt very, like they'd fallen down. And so, and part of them coming back was that, everyone was wearing a mask. Everyone had the same criteria. And then secondly, last point is that, the quarantine works. We pulled out of nursing homes early on. Our last day was before we had the outbreak. We never spread it to any of the nursing homes we go to. None of our hospital patients had it. And we had firsthand experience in seeing what the symptoms are like and dealing with it, patients on an outpatient basis. Which was not really something that was really focused on at the time. It was all focused on the hospital patients and patients that were really sick and needed to be in the ICU instead of all those patients that were, out in the community, which is what we've been dealing with from since that time. The cases have risen in Virginia, including in our area. And so, in terms of what we learned how to deal with an outbreak in our office. We learned how the spread worked, and we were able to track that and trace that. And we also learned how to be more compassionate and sort of more understanding of the patient experience because we have that firsthand experience. I think as doctors, a lot of times we feel like we're immune to things. We follow standard precautions. We wash our hands. We wear masks when there's a known infection. And so I think we go around thinking, okay, we're going to be immune, we're not going to be affected by this. But this hit us hard. But it also turned that we were adaptable. We were able to pivot in a matter of days of becoming a full steam in-person office practice to being virtual. And so I think it's both a cautionary tale as well as sort of hopeful that mitigation strategies do work. And as I said, it's a brave new world out there. We've become leaders in practice change, both on the hospital level. After our outbreak, they did switch to everyone wears a mask policy, for better or for worse. That was fought against for a long time, but now it's standard policy. We learn more about some of those atypical symptoms, such as the loss of taste and smell, and that was before that was widely known as well. So overall, I think we're the better for it. We're a little beaten up right now, but I think we've recovered. We stayed in business. We didn't have, it wasn't as disastrous as it could be, and we go forward like everyone else, especially now as we're facing the state in phase 2 and talking about kids going back to school in the fall and things like that. I think all the information we learned from this experience has been helpful in us as individuals, parents, as well as community doctors providing services in all those areas that we do provide the service.
Dr. Pasham, thank you. I'm so sorry that you and your staff and patients and families have had to go through that. And I'm also grateful that you have done it gracefully and shared it with us. Thank you very much. I'd like to just make some quick closing remarks. I think that this has been a remarkable conversation, and we've maybe bitten off a bit more than we could chew for 1 hour, but be that as it may, we've been able to talk about several at-risk patient and caregiver populations. We've been able to talk about a very, very difficult and unknown situation that puts our vulnerable populations and ourselves at substantial risk. It really is a perfect storm. And yet, as Dr. Abu Bakr pointed out, one of the things we can control is fear. Now, we would be naive to say that there's nothing to fear but fear itself. There most certainly is, but we also are seeing stories of how to take care of one another as healthcare providers and thereby take care of our patients in our communities. So thank you, everybody, for sharing in that. We will be able to field additional questions as they come in after participants around the state are able to see this presentation. So VDH will be in touch with all of the presenters today about that. VDH additionally continues to have relevant COVID-19 information updated on their site. And there are a number of resources, particularly regarding testing as new protocols for that emerge, and some sites specifically for providers. So hopefully that will continue to be a benefit to all of us as we move forward through these difficult times. Thank you very much, Hector. Thank you. The additional questions can be linked as shown, and we will hopefully see everyone next week. Thank you very much.
Thank you.
Thank you.
Thanks for inviting us.